లాస్ట్ రూమ్ వచ్చేట
நிறுத்தணும்.
நீ போய் நிறுத்து. இது
ஸ்டாப் பண்ணணும்.
அந்த எல்லோ பட்டன் ப்ரெஸ் பண்ணு.
Mangai, please go ahead.
Yes, ma'am. Very good evening to one and all. We welcome you to the Deccan Positive Mental Health webinar series. Today, resource person Anita Ramachandran, School Counselor, Sharjah, UAE. We welcome participants and teammates on behalf of Manasa Subkara Mindcare, Hyderabad, in association with Hello Bond Counseling Center, Hyderabad, India, Forest Creative Hearts Studio, Punjab. Thank you. Over to intro section.
Thank you, ma'am, for that wonderful welcome note. And today's our resource person is Anita Ramachandran, ma'am. Ma'am has completed bachelor's in sociology as well as in education university, master's in social work, and now currently pursuing MSc applied psychology. Ma'am has been conducting different webinar sessions on variety of topics, and she also be a coordinator for international mental health webinar series organized by American College Madurai. Ma'am has been counselor for 2 years and a recipient for Sarvapalli Radhakrishnan Award by Red Pond Educational and recipient for International Global Teaching by Excellence of Award. And she also be a member in TADAM, aims to create awareness on mental health and aspects of communication. Ma'am has been approved as an Ministry of Education and UAE approved primary grade school teacher with outstanding classroom management. She has been possessing vast experience of in diverse academic settings and developing lessons for a wide range of students. She has also been experience of 15 years in teaching. Happy to have you, ma'am. The floor is yours. You can go ahead.
Yeah, good evening, everyone, and thank you so much, Mangai ma'am and Naveen, for that wonderful introduction and a welcome address. And I would like to thank the organizers of the Deccan Positive Mental Health team for giving me an opportunity to be here and to speak about one of the major mental illnesses called schizophrenia, about the treatment and management of schizophrenia. Without any further ado, I would like to go on to the session. Schizophrenia, as we know, has puzzled physicians, philosophers, and the general public for centuries. The systematic study of schizophrenia, however, is but a century old, a clinical syndrome with a profound influence on the public health. Schizophrenia has been called arguably the worst disease affecting mankind, even AIDS not accepted, by Nature in 1988. To understand what schizophrenia is, it is important to have a brief look at the history of the evolution of the concept of schizophrenia. Although earlier descriptions of schizophrenia, like illness, were recorded in literature as old as in Ayurveda, Morrell's description of what he calls as dementia precox, Carl Baum's description of catatonia. Catatonia has been one of the types of schizophrenia later. Hecker's description of hebephrenia. Hebephrenia is also a type of schizophrenia, as we will see it later. In brief, the scientific study of the disorder began with the description of dementia precox by Emily Kraepelin. Now, Emil Kraepelin in 1896 differentiated the major psychiatric illnesses into two clinical types. One is dementia precox, and the other is a manic depressive illness. That means an affective disorder where you have a swing from mania, that is being very, very happy, to a very, very depressed state or a sad state. Under dementia precox, he brought together various psychiatric illnesses such as paranoia, that means paranoid schizophrenia, catatonia, catatonic schizophrenia, and hebephrenia, also hebephrenic schizophrenia, which were earlier thought to be distinct illnesses. The emphasis in diagnosis of dementia precox was that there was an early onset and a very, very poor outcome. Dementia, called it dementia also, deterioration. Precox means early onset, something with an early onset. He also recognized the characteristic features of dementia precox, such as delusions, hallucinations, disturbances of affect, and motor disturbances. Eugen Bleuler, while renaming dementia precox as schizophrenia, meaning mental splitting, he called it mental splitting, recognized that this disorder did not always have a poor prognosis as described by Kreplin earlier. He also recognized that schizophrenia is a group of disorders rather than being a distinct entity. Therefore, he termed group of schizophrenias. Bleuler also described the characteristic symptoms, that is, some of the fundamental symptoms which is there in schizophrenia, which were then thought to be, thought to favor the diagnosis of schizophrenia. He also described some of the other accessory symptoms of schizophrenia thought to be secondary to the fundamental symptoms. These accessory symptoms included delusions, you had hallucinations, and negativism. As I go on with my presentation, I will explain each one of it. Now, according to Bleuler, Eugen Bleuler, he describes some of the fundamental symptoms of schizophrenia. He called it 4 A's of Bleuler. First is ambivalence. A patient, I'm using the word patient because we're talking about a clinical setting, and marked inability. Ambivalence means there's a marked inability to decide for or against. For example, if a patient wants to lift his hand, he doesn't know whether he has to lift his hand or he has to put it down. When I just, for example, if I just take his hand, he might just withdraw it back. So he's not very, very clear about what he has to do. Autism's features, withdrawal into self. Sunanda ma'am, I think PPT is not visible here, ma'am.
Yes, Anita. Naveen?
Yes, I'm late, ma'am.
Yeah, ma'am. I will check that. You can go ahead.
Ma'am, I will share
Yeah.
now, ma'am. It's a network issue.
Yeah. The first thing is ambivalence, marked inability to decide for or against, autism, withdrawal into self. Those autistic features which these children exhibit. Now, affective disturbances of affect such as inappropriate affect, sudden outbursts of crying, okay, and then emotional outbursts also, you can see, describe it as an affect, and which is there for a very, very short period of time. Association disturbances, that means loosening of association and an evidence of thought disorder. So these were the fundamental symptoms described by Eugen Bleuler. Again, another person, Kurt Schneider, in 1959, described symptoms which are not specifically there for schizophrenia, were of great help and to make a clinical diagnosis of schizophrenia. These are popularly known as Schneider's first-rank symptoms of schizophrenia, as you call it, and also it is also called FRS or SFRS, first-rank symptoms. He described the second-rank symptoms of schizophrenia, which were considered by him as less influenced and which contributed to the diagnostic criteria and classification of schizophrenia and other related psychotic disorders. As mentioned earlier, the first rank symptoms are not specific for schizophrenia, may be seen in other psychiatric disorders also, such as mood disorders and organic psychiatric disorders. What are the first rank symptoms that Kurt Schneider has given? Very important is audible thoughts, voices speaking out thoughts aloud. That means thought echo. A patient hears his own thoughts. That means it's echoing and he's hearing it. Second, voices heard arguing. Two or more hallucinatory voices which discuss the subject or the patient in the third person. That means there are two voices which discuss, saying that he's lifting his hand. Look at him, he's lifting his hand. He's touching his head. He's touching his nose. He's going out for a walk. So two people are discussing that. Next, two voices commenting on one's actions. It can be many people commenting on one's actions. The fourth one is thought withdrawal. Thoughts cease. That means the person experiences a feeling that thoughts have stopped coming into his mind and he experiences as if it is being removed or withdrawn by another external force. So these are the strange experiences which the patient reports. thought withdrawal, thought insertion, experience of thoughts imposed by some external force in person's passive mind. We must understand that thoughts are very, very private to the individual, and we do have a control over sometimes our thoughts. But what happens in a person with schizophrenia and with the first rank symptoms is that these thoughts are either inserted into the person's mind, or there are strange experiences as if the thoughts are being withdrawn out of the patient's mind. The other thing is that thought diffusion or broadcasting. What do we mean by the term broadcasting? Can someone tell me what do you mean by broadcasting? What do you mean by broadcasting? Yes, participants, friends?
Broadcasting is how we take up the thing, summarize, and tell it to the others, or how we present it to others.
Okay, how we present it to others, or it is known to others. See, messages are broadcast. We have the different medium of communication, okay, the radio and the television, where messages are broadcast. What happens? Thank you, ma'am. Thank you so much. Thought diffusion or broadcasting, experiences of thoughts escaping the confines of self and as being experienced by others around. So all the thoughts are being known to others. It is being broadcast outside. So this makes the patient very, very, puts the patient in a very uncomfortable position. Now, again, made feelings or affect. See, we have a control over our feelings and affect. Do you all agree with me? We have a control over the made, over the feelings and affect. That is our emotional expression. Do you all agree with me? Friends here? Yes. Any responses to that?
Yes, ma'am. You're in mute. Anita, ma'am, you're in mute.
Yeah, thank you, ma'am. Now, made feelings or affect. Now, feelings or the affect, the emotional expression which is there for a very short period of time is being controlled by someone else. So this patient experiences such feelings, that his feelings or his affect is being known to others, and they are trying to control his effect or his emotions and feelings. Now, made impulses. There are some actions which are being controlled by the others. Now, made volition or acts. In made affect, impulses and volitions, the person experiences feelings, impulses or acts which are imposed by some external force. There is some external force which is controlling it. So there are certain things which is in our control, some of our actions and all that. And now the patient here feels that his volition and his acts are being controlled by some external force, which puts him in a very, very difficult and uncomfortable position. In made volition, for example, one's own acts are experienced as being under the control of some external force. Somatic passivity. There are some next thing is somatic passivity, where bodily sensations, especially sensory symptoms, are experienced as imposed on body by some external force. For example, if a patient wants to lift the hand, he says it is a voluntary movement. Now, there is an outside force which is controlling and telling him that your hand, I'm going to lift your hand. So it's not, the patient will tell you during the interview, he will tell you that the hand is being lifted by someone. So that is called somatic passivity. He wants to keep his hand, but his hand is being lifted by some other external force. Again, there is a next thing called delusional perception. Normal perception has a private and illogical meaning, and a person attaches a meaning to make a diagnosis of schizophrenia. So that is called delusional perception. It goes to the extent of being a delusion in a person diagnosed to have schizophrenia. According to the World Mental Health Report 2001, about 24 million people worldwide suffer from schizophrenia. The point prevalence of schizophrenia is about 0.5 to 1%. Schizophrenia is prevalent across racial, socio-cultural, and national boundaries, with a few exceptions on the prevalence rates in some isolated communities. The incidence of schizophrenia is believed to be about 0.5 per thousand, and the onset of schizophrenia usually occurs later in women and often runs a relatively more benign course as compared to men. The ICD-10, that is International Classification of Diseases 10, gives some of the criteria to make a diagnosis of schizophrenia. For example, thought echo is there, which I have already mentioned. Thought insertion is there, thought withdrawal, thought broadcasting, delusions of control, influence or passivity, which I have already explained, clearly refer to body or limb movements or specific thoughts and actions or sensations and delusional perception. So at least one or two of these, if a patient has, you can clearly make a diagnosis of schizophrenia. Hallucinatory voices, that means the patient hears a lot of voices without a stimulus to the sensory organs, I mean the sense organs. Hallucinatory voices running a running commentary on the patient's behavior or discussing him or her between themselves. That is what I said. Two people are discussing the patient, or many voices are discussing the patient, or other types of hallucinatory voices coming from some part of the body. I will explain all that a little later. Culturally inappropriate or implausible persistent delusions are there, for example, related to religious beliefs, political identity, superhuman powers, and abilities. The disorders of perception, that means when there is no hallucinations occur when you do not have a sensory stimulus, or there is no stimuli to the sense organs. Hallucinations are perceptions of a non-existent object. Objects are not there, but the patient is perceiving that there is an object or event, and certain sensory experiences that are not caused by stimulation of the relevant sensory organs. The word hallucinations comes from the Latin word which means to wander mentally. In layman's terms, hallucinations involving hearing, seeing, feeling, smelling, or even tasting things that are not real. They are not present. See, when there is no food, and then your nose is able to smell something. So that is a hallucination. When you don't see the food there, and yes, this one. When there are no people talking, and then you're hearing some voices. For example, someone might hear voices that aren't there or see patterns that others don't see. It is caused by a mental disorder. Hallucinations occur frequently in people with psychiatric conditions, including schizophrenia and a bipolar disorder, that is the affective disorder, which has mania and depression. Now, however, you don't necessarily need to have a mental illness to experience hallucinations. Sometimes hallucinations can occur in organic conditions also. Sometimes temporal lobe epilepsy can result in hallucinations. No matter what causes hallucination, they should be taken very, very seriously. At least one or two of the following are there. Persistent hallucinations in any modality, when accompanied by fleeting or half-formed delusions without clear, effective content, persistent overvalued ideas, or occurring every day for weeks or for months, and breaks of interpolations in the train of thought. There's a continuity in the thought process. If there is a break in that, or if there is the patient is not able to think properly, resulting in incoherence or irrelevant speech or neologisms. I'll explain all this as I go through the slides next. Catatonic behavior, which is also a type of schizophrenia, where you see a lot of excitement, sudden excitement, you have posturing. The patient remains in the same position for a very long time. They usually respond very quickly. Waxy flexibility, as you see it in catatonic schizophrenia, where you have when you take wax and when it is very hot and you put it into a vessel, what happens to the wax? It settles down in the vessel and then takes the shape of the vessel, is it? So what happens in waxy flexibility is that when you take the patient's hand, you can actually bend it like wax and patient will keep it in the same position. Is it clear?
Yes, ma'am.
Okay.
Yes,
Again, negativism is when the patient will not obey your commands. When you ask him to come here, he will just walk away. He refuses to obey your commands. Mutism, when he doesn't speak anything. You sit there for 2 hours as a therapist, and then he's not going to speak even a word. So you come back. Again, you're a state of stupor. Suddenly he's sitting like that. It's something like a statue. You have to understand that. It's something he behaves like a statue. He's in the same position for a very long time. He does not respond back to anything. So as a therapist, we have to make a note of all this behavior. Now, negativism, as I described it, an apparently motiveless resistance to all commands and attempts to be moved. If you ask him to move, he's not going to come here. He's going to refuse, or just he will do the opposite. Now, stupor, akinesis, no movement with mutism. There's no speech. You sit there for 3 hours, he's not going to speak. So you take the interview on the next day after you've given him some medicine. The other day also, he's not going to respond. So you will go back to the next day to, collect all the symptoms or some of the psychopathology. But with evidence of relative perseveration of consciousness, he's aware of it. He is aware of what is happening. And some of the negative symptoms, we have what is known as the positive symptoms and the negative symptoms. Positive symptoms, you have hallucinations, you have delusions, and you have thought disturbance, and you also have bizarre behavior, which is seen there as a reflection of the thought process. And negative symptoms are marked apathy. There's no interest in anything. Positive speech, he does not want to speak. Blunting, there's no expression on his face. Incongruity of emotional expressions, that means sudden outbursts of crying. So this kind of behavior is seen, which is not which does not go with the situation. A significant and consistent change in the overall quality of some of the aspects of personal behavior manifests as loss of interest, aimlessness, there is no aim in the activity, idleness, just sitting and staring at something and looking and smiling to self and talking to self, self-absorbed attitude, and social withdrawal. If a person has been moving around with friends and he's been going around, he doesn't want to do that anymore. He has no interest in whatever it, that's called anhedonia. Now, schizophrenia is characterized by disturbances in the thought process, verbal behavior, perceptual disturbances are there, affect your emotional expression, motor behavior, as we have seen in catatonic schizophrenia, and a relationship to the external world. As I've already mentioned, you have what is known as the first rank symptoms. You have audible thoughts, voices hearing and arguing with each other, which makes it more and more difficult for the patient to be very comfortable. Two more hallucinatory voices discussing the subject in the third person. He's doing that. He's lifting his hand. He's putting his hand on his head, and then he's touching his nose. He's touching the table. He's writing a letter. So these are the kind of commentary, running commentary, which the patient hears. Voices commenting on one's action, thought withdrawal, and thought insertion, as I've already mentioned. When you take the thought process, there are two things. You have what is known as form of thought, and you have what is known as the content of thought. Content of thought becomes a delusion. Okay, thought and speech disorders. Autistic thinking is one of the most classical features of schizophrenia. Here, thinking is actually controlled and governed by private illogical rules. The patient may consider two things identical because they have identical predicates or properties. For example, Lord Hanuman, it's just an example which I've taken, was celibate. I'm celibate too, so I'm Lord Hanuman. the form of thought, a disturbance in actually the form of thought is often present in schizophrenia. It's called the formal thought disorder. When you have formal thought disorder, you have what is known as the loosening of associations. There's a pattern of spontaneous speech that comes in which things such as juxtaposition lacks a meaningful relationship, or there is an idiosyncratic shifting from one frame of reference to another. The patient quickly shifts from one idea to another. There is no continuity in the flow of thoughts, and he is not able to bring that out in his speech. The speech is often described as being disjointed. If the loosening becomes very, very severe, speech becomes incomprehensible. You're not able to understand because there is no connection between the ideas. This is called incoherence. So there is no connection between one idea and the other. So there is a loosening of all the association. The thoughts are not associated. And in fact, the speech that comes out, the output of the speech that comes out has no connection. Now, poverty of content of speech. Speech is adequate in amount. Speech is there, but conveys very, very little information, which is very, very vague, which is not clear, abstract, repetitive, or stereotyped. Again, this can also be seen in major depression, poverty of content of speech, and also seen in schizophrenia. Thought blocking. The next thing is thought blocking. When you take the thought process, is an important feature in schizophrenia, although it can also be seen as complex partial seizures. Temporal lobe epilepsy people have what is known as a thought blocking. But again, it is also seen in schizophrenia. There is a sudden interruption in the continuity or the stream of speech before the thought is completed. After a pause, the subject is not in a position, that is, the patient is not in a position to recall what he has to say. This may at times be associated with thought withdrawal. He says, my mind is very, there are no thoughts in my mind. It is just being taken out. So there's a thought block in my head and I'm not able to think clearly. I'm not able to recall any facts and tell you. You have what is known as neologisms, which is also seen in schizophrenia, where you don't have these words framed by these patients. It is not there in the dictionary, but the patient attaches a special meaning and gives a meaning to those words. Neologisms are newly formed words or phrases whose derivation cannot be understood. These are created to express a concept for which the subject has no dictionary word. Sometimes normal words are used also in an unconventional or distorted way, but the derivation can be understood, even if it is very, very bizarre or strange or unusual. These are words or word approximations or paraphrasias. For example, describing the stomach as a food vessel. So neologisms are those kind of strange words which the patient attaches a meaning. Now, a patient with schizophrenia may show what is known as mutism. There is no speech at all. He does not speak. You sit with him for sometimes in some patients. See, sometimes you must understand that different patients exhibit different kinds of symptoms, and based on what information they give, we have to make this one. And taking the family history also, that will also help us to arrive at a proper and accurate diagnosis. Poverty of speech, decreased speech production. There is no this one. Speech is less. Poverty of ideation. Speech amount is adequate, but content conveys very, very little information. So you have mutism, you have poverty of speech where there's no decreased speech production, few words, and then there's nothing, no message gets conveyed. Poverty of ideation. Speech amount is adequate, but content conveys little information. You have what is known as echolalia, which is also seen in catatonic schizophrenia. For example, when they start talking. Echolalia, for example, if the therapist lifts a bottle to drink water, the patient will also do that, repeating the same words, echolalia. Echopraxia, the actions are repeated. For example, if I take the bottle and then the patient is also going to take the bottle, that is echopraxia, repeating the actions. Echolalia, which is also repeating what this one, how are you feeling today? How are you feeling today? So repetition of the, the phrases or the words or the sentences which the therapist is speaking. Perseveration, persistent repetition of words beyond their relevance. There is no relevance to what, but the patient continues to repeat those words. Verbigration is also there, senseless. There is no meaning to it, but he repeats the same words or phrases over and over again. These are the disorders of verbal behavior or the speech. Now, there are two things in this: clanging, speech in which the patient makes some strange sounds rather than meaningful conceptual relationships or words. Choices, it may include rhyming words and punning. Rhyming. For example, punning may be like, for example, I'm not trying to make noise, but I'm trying to make sense. So that's punning. If you make sense, rhyming is if you make sense out of nonsense, well, have fun. I'm trying to make sense out of sense. So that is a rhyming thing which the patient comes out with. Now, thought blocking. These are all, this would come under the formal thought disorder, blocking, interruption in the train of thought or train of speech. There's a thought and then thought gets blocked. Patient is not in a position to speak before a thought or idea has been completed. After a few seconds to minutes, person cannot recall that he has been saying or what he wants to say. So there's a thought block. Suddenly he says, thoughts have stopped coming into my mind and I'm not going to speak anything. He will not say anything. He's not in a position to think. Tangentiality, speech, when you ask him a question, speech that is indirect and without reaching the goal includes unnecessary details and tedious details. He does not come back at all. He does not come back, so he will give you a fact that is just near the question that you have asked, but he will not give you the exact answer. He will just wander away and give you all irrelevant information. Now, circumstantiality, goal is usually reached. He will just move around, he will tell you many details, and then finally come back to the question that you have asked. That is called circumstantiality, just wandering around, coming back to the topic or the question that you have asked. Perseveration, persistent repetition of words, ideas or subjects, so that once an individual begins to speak about a particular topic or uses the word repeatedly, I think I shall put on my hat, my hat, my hat, my hat. So this is perseveration, repeats the word without any meaning there. I hope I've made myself clear so far. Sunanda ma'am?
Yes, ma'am. Absolutely clear.
Okay. Delusions.
Gopal sir, you want to interact? Gopal sir?
Yes.
Okay, ma'am. You please
Yes,
go
sir.
ahead.
This one, okay. You can just make a note of all the questions and like later on, you can ask me also. Now, when you take delusions, these are false, unshakable beliefs that are not in keeping with the socio-cultural and educational background. These are of two types, primary and secondary. So we've seen the formal thought disorder, which is a disorder of the form of thought. So we had loosening of associations and other things in that. Delusions means you have to take the content of what is being spoken. Now, primary delusions cannot be explained on the basis of other experiences or perceptions which the patient has. Also known as autococcus delusions, these are thought to be characteristic of schizophrenia and are usually seen in the early stages of the illness. Secondary delusions are the commonest type of delusions seen in clinical practice and not diagnostic of schizophrenia, as they can also be seen in other psychotic disorders. You have delusional disorders, you have delusions caused by substance abuse, and again you have what is known as substance abuse is there, and again organic conditions also can cause delusions. Secondary delusions can also be explained as arising from other abnormal experiences. Now, coming to the content of thought. So we have seen form, now it's the content. The commonly seen delusions in schizophrenia include delusions of persecution, being persecuted against, people are against me. So this is the idea that the person believes in, which is not true. Delusions of reference, being referred to by others, people are talking about me. There are two people talking about me. They're looking at me. They're plotting against me. They're always speaking about me. They're discussing things about me. Delusions of grandeur, usually seen also in affective disorder, where you have a manic phase where the person is found to be excessively happy. So I'm the king. So he could just go with that. And delusions of grandeur can also be seen in schizophrenia. Exaggerated self-importance. I'm God Almighty. I have superpowers. I'm the Superman and I can rule the world. I'm a great leader. Delusions of control, being controlled by an external force known or unknown. For example, my neighbor is controlling me. Somatic delusions can be there, or hypochondriacal delusions can be there. For example, there are insects crawling in my scalp. Insects might not be there. When you ask the family, they will tell you that there's nothing like that which happened. But again, patient believes that this is true. Somatic delusions can be there. Main content pertains to the functioning of one's body. My brain is rotting, for example, my brain is rotting. Nihilistic delusions can be there, involving the theme of non-existence of the self or part of the self or others to the world. I no longer have a brain. Patient will tell you that I no longer have a brain and the world is finished. Delusions can have the religious content also. They have predominantly religious themes sometimes, and it is also related to the cultural beliefs. He's a messenger of God. A particular religious book was written by me. I have written that book. Delusions of jealousy can be there also. Now, delusions of, there are other delusions like delusions of jealousy. The patient could be jealous of the others. Patient could also have delusions of infidelity. He could be suspecting his wife or the husband, either of them, that they're having an affair, extramarital affair, or an affair with some other person. Again, it's very common in substance abuse, which is there, okay? When substance abuse leads to psychotic phenomenon. The other clinical features of schizophrenia thought disorder include over-inclusion, tending to include irrelevant items in the speech. Something that is not required and the patient is going to include all that. Impaired abstraction, loss of ability to generalize. He's not in a position to see the abstract concepts. Concreteness again is impaired due to the impaired abstraction. Perplexity, he's really puzzled and he doesn't know what to do. Ambivalence is also there. Again, he doesn't know whether to go or to move forward or to come back. He's not very clear. There's a confused state. Now, delusions of perception as the first rank symptoms. Hallucinations, perceptions without stimuli are common in schizophrenia. Auditory hallucinations are very, very frequent. Other kind of hallucinations can be there. For example, elementary auditory hallucinations, hearing simple sounds rather than voices can be the elementary auditory hallucinations. Thought echo, patient hears his own thoughts, audible thoughts. Third person hallucinations, two people or many people are discussing the patient's actions or, this one. Voices commenting on one's actions. Only the third person hallucinations are believed to be a characteristic of schizophrenia. Visual hallucinations can also be there in schizophrenia with auditory. Most common are visual and auditory hallucinations, which is seen in schizophrenia. Now, tactile, again, related to the skin, the gustatory, something related to the gastro, this one, intestinal, this one, and olfactory, smell. These types are less common. They are found mostly in the organic conditions. And schizophrenia is a functional disorder, as all of you know. Disorders of affect. The disorders of affect include apathy, emotional blunting. There's no expression. For no reason, the patient appears to be very sad and there's a flat expression on his face, emotional shallowness. He's not able to relate to people. He's not able to communicate much to people. Anhedonia. He's not able to experience any kind of pleasure with which was there earlier. For example, meeting friends, interacting with them. So all that has declined over a period of time. Inappropriate emotional response inappropriate to what is there in the thought. So the situation might be very quiet. And then he comes to a therapist, and then suddenly there's a sudden outburst of crying, emotional outburst there, so which is not appropriate to the situation. The difficulty of a patient with schizophrenia in establishing emotional contact with other individuals can lead to a lack of rapport with the physician or the doctor. This can often happen. Again, we have what is known as the disorders of motor behavior, which is seen in catatonic schizophrenia. They can be either a decreased spontaneity, inertia, or stupor, or an increase in psychomotor activity. Psychomotor activity, we are referring to the thought process and the actions, the motor activity associated with the thought process. Sudden excitement is there, aggressiveness is there, restlessness is there, pacing up and down, agitation, getting irritated with people, mannerisms, again, grimacing, winking, those kind of mannerisms, stereotypes, repetitive strange behavior. There is no purpose for the behavior, but patient will continue to do it. Decreased self-care, poor grooming are some of the common features. Yes, I will share the PPT. There's a request from one of our this month to share the PPT. I will share it. Catatonic features are commonly seen in the catatonic type of schizophrenia here. Now, you have what is known as the positive symptoms and the negative symptoms. Negative symptoms are more difficult to handle. It is very difficult for the mental health professionals to handle the negative symptoms. Positive symptoms, sometimes they respond very quickly, but again, a chronic course, lifelong medication would be required. Negative symptoms, the prominent negative symptoms of schizophrenia include affective flattening or blunting. There is no expression on the face, and attentional impairment. He's not able to concentrate on a particular task, avolition, apathy, lack of initiative associated with psychomotor slowing. He's just sitting there and then watching something. Anhedonia, there's no interest in pleasurable activities. Social withdrawal from others, asociality, alogia, lack of speech output. Patient does not speak. There's a poor verbal as well as non-verbal communication with poor facial expression, decreased eye to eye contact. He would probably be looking at something, staring at something, or looking away from the therapist, with usually poor self-care and poor social interaction. Other features being decreased functioning in work, social relations, and self-care as compared to the earlier levels achieved by the individual. Everything was all right. Suddenly, the family finds that there is a lot of change in the behavior they have observed. They are not in a position to understand what has happened suddenly. It takes a very long time for them to recognize that something is wrong. They would probably go to the other doctors and then find out and finally go to a psychiatrist. Loss of ego boundaries is there. There is the thoughts are known to others. Thoughts are very, very private to the individual. When it is known to others, it puts the patient in a very uncomfortable position. Loss of ego boundaries are there. Feeling of blurring of boundaries of self with the environment, uncertainty and perplexities or some kind of confusion regarding one's own identity and meaning of existence. Multiple somatic symptoms can also be there during the early stages of the illness, and insight is usually absent. A person does not realize that there is a need for him to go to a psychiatrist, and he would say that everything is fine and there was something wrong with my behavior that I was brought to a psychiatrist, but I'm perfectly all right. So insight is not there, judgment is not there. So insight is absent. So the family has to take a lot of effort. They have to make a lot of effort to take the person to a psychiatrist. Social judgment is usually very, very poor. There is usually no clinical significant disturbance of consciousness, orientation, attention, memory, and intelligence. Everything is normal there because it's a functional disorder. The patient could be very, very conscious. Only in an organic condition, there would be an altered consciousness. So a schizophrenia patient, if you talk to him, he would respond very well. There is usually a variability in symptoms. Every patient is different and every patient is unique over time. And some of the cases are clearly marked. There is no obvious underlying organic cause. For example, any blood test or urine test would not show symptoms of schizophrenia. It's just that as a therapist and as a mental health professional, we need to elicit the psychopathology to explain the causation of these symptoms. And there is no prominent mood disorder of any depressive or manic type. One important thing is that suicide, you have to watch out for suicidal symptoms in schizophrenia. Suicide and schizophrenia can occur due to several reasons. Some of the common reasons can include the presence of a comorbid depressive symptoms. Depression can be there. Command hallucinations. Command hallucinations, we are actually referring to person hears voices saying that you go and fall into the well, you slash your wrist. Okay, so those kind of command hallucinations can be very, very disturbing, and patient can blindly follow that. Commanding the patient to commit suicide also. Impulsive behavior, suddenly going and jumping into a well, that could also happen. The behavior, presence of anhedonia, there's no interest in any kind of activity which was considered to be pleasurable earlier, or return or insight into the illness. Slowly, when we start the antipsychotic medication and other kinds of therapy, it is found that patients develop, some of them respond very well, and then they develop an insight into the illness. So that becomes a very, very painful thing for them experience. They are aware of the fact that they have suffered from a serious mental disorder like schizophrenia. So that can also lead to a suicidal, this one, depression can also be there. It is important to be aware of the possibility of suicide while treating a patient with schizophrenia so that the various risk factors can be addressed also in management. Now, positive symptoms, you have delusions and hallucinations. The table, Sunanda ma'am, the table one. Yeah. The positive symptoms, you have delusions and hallucinations, disorganized behavior, bizarre behavior. Negative symptoms, which you have affective flattening, alogia, there's no speech, poverty of speech, little speech is there, but there's no meaning, anhedonia, again, avolition, apathy, there's no interest in anything. Disorganized symptoms can be inappropriate affect, disorganized behavior. Patient is not able to organize his behavior. Thought disorder is also there. You have formal thought disorder there, and you have the delusions also, loosening of associations, as I had mentioned earlier, and formal thought disorder. Now, the International Classification of Diseases, ICD-10, has classified the schizophrenia into 4 important types. You have what is known as a paranoid schizophrenia, where you have delusions and hallucinations. You have command hallucinations there. Again, patient is hearing voices. You have delusions of reference, persecutory delusions, saying that someone is going to harm and someone is plotting against the person. Now, this has a good prognosis and they usually respond to medication, but it depends upon the duration of the illness. That also tells us about the prognostic factors. Hebephrenic schizophrenia, where the speech is disorganized in behavior, often very, very silly, shallow, flat, or inappropriate affect. When you see, the patient will be giggling without any proper reason. Catatonic schizophrenia, it's a psychomotor disturbance which we see. Undifferentiated schizophrenia. Catatonic schizophrenia is it is believed that catatonic schizophrenia responds well to the antipsychotic medication and other forms of therapy. And undifferentiated schizophrenia, where the onset is not very, very clear, they have a very, very chronic course, no specific symptom is there. Subtype predominates. Post schizophrenic depression also can be there. Some residual symptoms which is not very, very clear, which would help us make a clear diagnosis. But depressive symptoms again is a predominant feature of undifferentiated schizophrenia. Residual, again, we are not very, very clear. There is a very slow, insidious onset of the illness, and previous positive symptoms are not, they are less marked. Prominently, you have negative symptoms, which becomes a little difficult and hard to treat. It's more challenging to handle the negative symptoms. Simple schizophrenia, no delusions or hallucinations. Prognosis is quite poor. A defect state, negative symptoms are predominantly seen. onset is not very clear. There's a gradual deterioration of the patient's functioning arises without an acute episode, a simple schizophrenia. So these are the kinds of schizophrenias. Again, the treatment, it is important for us to assess the symptoms and establish an accurate diagnosis. Establish an accurate diagnosis considering other psychotic disorders, and we will be ruling out those other diagnoses and have a proper symptom which will lead to and make us, have a diagnosis of schizophrenia. And a definitive diagnosis cannot be made, but the patient appears prodromally symptomatic and at risk for psychosis. So you will have to, as a therapist, you will have to reevaluate the patient frequently. Every follow-up, you will ask the patient to come, and you will also interview the family members to find out and the level and functioning and the progress that the patient has made and how he has responded to the medication. Coming to the treatment, the first drug that was used, which had a very good effect in schizophrenia, was probably reserpine, which is an old thing which was which was discovered by Sen and Bose in 1931. Reserpine is no longer used for the treatment of schizophrenia because it was producing a lot of side effects, including its propensity to cause severe and suicidal depression. So they have removed it. Antipsychotics were formally discovered by Delay and Deniker in 1952. Since their introduction, they have changed the outcome of schizophrenia significantly. Now, there is a need, if there is a need, so we have what is known as, you have an inpatient and an outpatient in a hospital. So inpatient, there is a need, there are some factors which tell us that there is a need for the patient to be hospitalized. Now, issues affecting the initial management decisions. The family has had a difficult time. The patient does not realize that. So the family has a lot of difficulty. They need a lot of support and encouragement in whatever decisions, and we have to respect their decisions. Certain clinical features and situations will determine whether hospital admission is required or they have to be transferred to a psychiatric ward. So in a psychiatric ward, when I studied in NIMHANS, we used to have what is known as the open ward and the closed ward. Open ward, where a patient can be managed and the family members can stay there, but the patient and the family members will be monitored there, the kind of progress regarding the medication, the other forms of therapy. So patient will be monitored. And when there is a closed ward, again, when the patient has become unmanageable, there's violent behavior, aggressive behavior towards relatives and to other people, and that is one thing. Again, to monitor the medication also, patient can be put in a closed ward. Closed ward, the other indication for putting a patient in a closed ward is when they have committed some crime. So we have the police in the criminal ward there, so we cannot give them any kind of punishment. They have to go for the treatment process, and then they will go to the correctional settings. There is a high risk of suicide or homicide. Now, when there are no
Shall we
relatives, also
conclude today's
patients.
session? Anita,
Yes,
ma'am?
yes, ma'am. I have still a few more slides to go. I'll finish fast. And there is a high risk of
I think a
suicide
lot
or
of
homicide.
slides are there, ma'am.
Yeah. I'll finish it fast, ma'am. Other illnesses related behavior that endangers relationship, reputation, or assets. Severe psychotic, depressive, or catatonic symptoms are there. So these are the indications of hospitalization. The lack of capacity to cooperate with treatment, that can also become an indication for hospitalization. Lack or loss of appropriate psychosocial supports, when that is not there, patient can we can go for hospitalization. Failure of outpatient treatment, if the patient has not come for a follow-up, so outpatient treatment, in that case, we can think about hospitalization. So, and the psychiatrist and the other team members will decide that. Non-compliance with the treatment plan, that is another indication for hospitalization. If a patient needs to be monitored in terms of the medication and other forms of therapy needs to be given, again, there is a high risk of relapse. Hospitalization can be done, and need to address other comorbid conditions like depression. Hospitalization is there. Now, there are some good prognostic factors. When there's an acute or abrupt onset, the prognosis is quite good. Onset is if the patient has developed the illness after 35 years of age. Late onset, good prognosis there. Onset is less than 6 months. Chronic course, again, less than more than 2 years. There's a very poor prognosis. Presence of depression, again, it will also lead to this one. It has a good prognosis. Now, predominance of positive symptoms, good prognosis is there. Family history of mood disorder, good prognosis is there. First episode, good prognosis is there. Again, it talks about kinemic physique of the patient. Now, that has a good prognosis. Female sex has better prognostic factors. Again, bad prognosis, if you have a very, very insidious, slow onset, you have what is known as bad prognosis there. The absence of depression, again, can be, a bad prognostic factor. Predominance of negative symptoms, it's a bad prognostic factor. Family history of schizophrenia is there. It's a bad prognostic factor. Past history of schizophrenia, again, has a bad prognostic factor. Again, asthenic, thin physique, it's believed that they have a bad prognostic factor. Again, male sex, also, they have a bad prognostic factors. Good social support system and they are married, it has a good prognosis. Poor social support or unmarried, poor prognosis. Presence of confusion, perplexity or disorientation in the acute phase has a good prognosis. Flat or blunted affect has a bad prognosis. Proper treatment, good adherence to the treatment procedures, concordance and good response to treatment, good prognosis there. Absence of proper treatment or poor response to treatment has a bad prognosis. Outpatient has a good prognosis. Institutionalization, long-term hospitalization can lead to, it is one of the indicator of bad prognosis. Normal cranial CT scan in good prognostic factor. Again, evidence of ventricular enlargement in the brain, which shows that it has a poor prognostic factor. Now, antipsychotic medications, you have what is known, there are traditional medicines and atypical, atypical medicines also, which are given. Antipsychotics can reduce the risk of relapse in the stable phase of the illness to less than 30% per year. For most patients treated with first generation antipsychotics, clinicians should give a maintenance dosage and in fact, some of them withdraw the medication due to several reasons. It's because of sometimes they cannot afford to pay for the medication. That is one thing. The other thing is that severe side effects. These are called extrapyramidal symptoms, which is there, which can produce a lot of discomfort like dryness of the mouth, extra salivation, their hands start shaking. It is not Parkinson's disease we are talking about. This is due to the drug, the antipsychotic induced side effects with minimal rigidity detectable on physical examination. Second generation antipsychotics can generally be administered at doses that are therapeutic, but that will not induce extrapyramidal side effects. So sometimes drugs are given to reduce the side effects. Schizophrenia, again, there is an indication of ECT, the electroconvulsive therapy, when there's a catatonic stupor, uncontrolled catatonic, sudden excitement is there, acute exacerbation, not controlled with drugs. When drugs are not being, when it is being administered and patient is not relieved of the symptoms, ECT can be given. So, sometimes ECT can also produce side effects. When it's administered, 8 to 12 ECTs are given depending on the requirement. Again, reevaluate. When we have a follow-up, reevaluate the patient's diagnosis and update the treatment plan as new information about the patient and his or her symptoms become available. Mental status examination also needs to be taken at during that follow-up. Very important. Now, we have to identify the targets of each treatment, use some of the outcome measures that gauge the effect of treatment. We have to see how the patient has responded, and the family members would also be in a position to give us good information about the kind of improvement which is seen. But in no case should we allow the patient to withdraw the medication, because this is something which requires long-term treatment. Patient should be in a position to understand that. Now, again, you have certain rating scales, like positive and negative scales. So when they come for a follow-up, you can you can administer those scales and give scores, and so you will know the level of the symptoms. Now, formulate and implement an important treatment plan. This is also very important. Select specific type of treatment and the treatment setting. This process is iterative and should evolve over the course of a patient's association with a clinician. We have to establish a good rapport and develop a good therapeutic alliance and promote treatment adherence. That is very important. Identify the patient's goals and aspirations and relate those to treatment outcomes to increase treatment adherence. Make him understand that these are important things. Now, assess factors contributing to incomplete treatment adherence and implementing clinical interventions. For example, you can have a motivational interview to address them. Factors contributing to some of the incomplete treatment adherence include patients' lack of insight about the presence of illness or need to take medication. So he should be convinced to take the medication. They will argue sometimes, but we have to convince them. Patients' perception about the lack of treatment benefits, inadequate symptom relief and risk. Unpleasant side effects is something which contributes to that. They will not take medication. Again, discrimination associated with the treatment. There's a cognitive impairment, which is also seen the breakdown of the therapeutic alliance. They do not come back to the therapist. And there are practical barriers such as financial concerns or lack of transportation. Patient is not in a position to come and meet the team. Cultural beliefs and lack of family or other social support systems also contributes to poor adherence to treatment. Now, again, consider an assertive outreach, including telephone calls. The team members can decide who will make home visits and telephone calls for patients who consistently do not appear for appointments or for they're not adhering to the treatment procedures. Provide patient and family education and therapies. We have talked about psychoeducation and work with patients to recognize early symptoms or relapse in order to prevent full-blown illness and relapse of symptoms and exacerbation of other symptoms. Educate the family about the nature of the illness and coping strategies to diminish relapses and improve the quality of life for patients. Again, you have what is known as psychoeducation. One is for the family to learn the family education and also psychoeducation for the patient.
Ma'am, in upcoming sessions, we can take this, ma'am. SSI part 2.
Okay.
Yeah.
Okay. Yeah. So you want me to take you to the next session, ma'am?
Yeah, in upcoming months, you can take from treatment part of schizophrenia.
Yeah. Thank you so
Madam,
much
one small
for
question.
giving me an opportunity once again, ma'am.
Yeah, thank you, Anita, ma'am. Yes, Gopal, sir.
Yes.
Madam, this is a very nice presentation. Thank you very much. But, Madam, how to prevent this kind of schizophrenia? Is there anything available on that front, Madam?
How to prevent schizophrenia? See, there are biological factors involved. You have vulnerability to stress. Everyone is prone to have stress. We all have stress in our daily life, but there are some people who have a genetic load attached to that. So biological factors, stress factors, environmental factors, which contributes to the illness. So genetic factors are very, very important. For example, we've known families where 2 or 3 siblings have had schizophrenia.
Okay.
So genetic factors, if there are cousin marriages, when they get married within relatives, that also contributes to that. That can also contribute to this one because the vulnerability is more to stress. So we can prevent that. We can see once we get the illness, I think we have to take steps to, go for treatment, recognizing that is important. Very often what happens is that the family takes a very long time to recognize that because of the stigma that is associated with the mental illness. They don't recognize it, but it's again, time is also passed. And by the time it's like 6 months or maybe 2 years, the course of the illness also becomes very, very chronic. And, there's a lot of difficulty for them to respond. They will respond, but again, recognizing that is important.
Okay. And this noise comes means this is associated with the schizophrenia. That's all.
So sorry, I didn't get
noise,
you, sir.
Noise. The patients are hearing noise, some noises.
Yes.
That is simply associated with schizophrenia. For avoiding this noise, is there any treatment in the reinforcement, thinking of positive things, those kind of things? Is there any technique available,
Yeah.
madam?
Diverting the patient's mind into some other activity. It's
Yeah.
very difficult for us to motivate them and to make them perform tasks, because patient has been fine and suddenly they are seeing that the family suffers a lot because of this. Because we have to support the family, and diverting the patient's mind will be a good this one. Again, they respond usually to hallucinations and delusions. They respond well to antipsychotic medication. It's there for a while after they have started taking the medication, but again, other therapies can also be used to support the treatment process.
Madam, thank you, madam. And another thing,
Yes.
people at at higher level, some of the people, normal people, are having schizophrenic complaints. Like, is it true, madam? Even with the schizophrenic complaints, they can go to the top level of organization.
Definitely, they are gold medalists. I know a family where there was a gold medalist. The person was a gold medalist, and he was a very intelligent person. And then he developed the illness. Anyone can develop it, and the risk factors are more when you have a genetic overload.
Okay, after developing into schizophrenia, they cannot stand continue in that position. They will drop from there,
It will
correct?
be difficult because again you have cognitive impairments. Functioning becomes, they deteriorate in their functioning level. Self care is not there. Self grooming is not there. They cannot concentrate and perform any task. Best thing would be to put them into a rehabilitation center, and then
Mm.
get them involved into other tasks. Again, will the other people in the the workplace, will they accept them the same
Okay.
way?
Okay.
People might get a little frightened to interact with them. Again, that becomes a questionable thing.
Okay, ma'am. And
It
any
requires lifelong
psychotherapy,
treatment. Yes.
CBT, something like that, any psychotherapy which is
Yes,
more.
CBT is used. CBT is used. Cognitive behavior therapy is used.
Mm.
Cognitive behavior psychotherapy is used for this one, altering the kind of thoughts and all that.
Yeah. Thank you,
Okay,
Gopal.
thank you, madam. Thank you.
Yeah. Thank you.
Thank you very much,
Welcome.
madam.
Yeah.
Excellent session.
Most
Kalyani,
welcome.
ma'am.
Good evening, everyone. It was a very good session, wonderful session. Could I just add on here that one of the reasons for schizophrenia is also trauma. When people go through a major trauma, no, after that also it could happen. I just wanted to add on. I don't know if it was mentioned by you, maybe I missed it. But I think trauma is one of the major causes of schizophrenia. I just wanted to add that. Thank you.
Thank you, ma'am.
Thank you, ma'am. Yeah. Kavita Rajagopalan.
Good evening, ma'am. And the session was so wonderful. Thank you for that. I just wanted to ask you, if there is a continuous seizures happening for a special need child in a temporal lobe, will it lead to schizophrenia in the future? What are the possibilities of becoming to?
For example, when you're talking about seizures, epilepsy as we call it, it's like it is a neurological problem where the electrical discharges are involved. More number of electrical discharges are there in the temporal lobe. It might not lead to schizophrenia, but again, epilepsy, you can develop psychotic features with epilepsy. If there's a family history, again, there are high chances that the child may not develop also.
Psychotic features. Okay, madam. I'll
Psychotic
just
features. I'm
go
talking
through
about
like what.
hallucinations and delusions. Yes, yes. As a result of the epilepsy.
Okay.
Organic conditions sometimes can
But
lead to
if
psychotic features. Yes.
if the medicines are taken for that regularly for that seizures, the possibilities will be less, right, to get addressed.
Yes, ma'am. You have to go to a neurologist to take medication for epilepsy. Once you have epilepsy, at least for 5 years, you have to take medication. Child or the person should be fit free, should not have epilepsy for the next 5 years. Again, you have to monitor this one. Again, stressful situations can also trigger off, the epilepsy. We do
Yes,
not know.
sure.
Child should not be made to go
True.
near the fire or should not meet with an accident. Swimming pool should be avoided.
Even a louder noise. everything. Thank you.
Loud noise
Thank
can
you.
also trigger sometimes. And once it occurs,
Yes.
again, you have to go for a follow-up to the neurologist.
Sure, ma'am.
I
Thank you so
answered your
much.
question, ma'am. Thank you.
Thank you, Kavita ma'am. Yeah, I think no other doubt, ma'am. Shall we conclude today's session? Can take a part 2 as a treatment, ma'am.
Sure.
Next month, yeah,
Sure, ma'am.
in upcoming months. Yeah,
Sure.
thank you, ma'am. It
Thank
was
you
a,
explaining, ma'am. Thank you for patiently explaining. Thank you.
yeah,
Thank
thank you,
you,
Thank you
Anita
so much,
madam.
ma'am.
Thank you.
thank you,
Excellent
Gopal.
session, Anita madam.
And thank you, ma'am, for
Thank you very much.
coordinating. Thank you so much.
Thank you, ma'am. Excellent
Yeah, it was a
session.
Thank you,
wonderful
ma'am.
session,
Welcome,
ma'am. We
most welcome.
thoroughly enjoyed. It was a insightful and informative session. We thank from Deccan Positive Mental Health and in association with the Yellow Pond Counseling Center India and Forest Creative Arts from Punjab. We thank you all, friends. Have a happy Christmas and happy New Year ahead. Next week we meet. Yeah, good night,
Yeah,
Anita.
thank you so
Merry
much,
Christmas and
everyone, for
Happy
your
New Year, ma'am.
patient listening. Yeah, thank you, and advanced wishes for Christmas, and wish you all a very, very happy New Year. So see you
Same
all
to you,
next
madam.
week on
Yes,
Same to
Friday.
thank you,
you.
friend.
Thank you. Bye,
Thank
Sunanda,
you.
ma'am. Thank you.
Okay, thank you, Samantha. Bye.